Welcome to another episode of Clot Conversations from Thrombosis Canada. I'm David Airdrie, Executive Director. And today we're doing another episode from the ISTH for Monday, July 11th. Our guest today will be discussing highlights from presentations that they attended and key insights that they took away from the presentations. Thank you for joining us. Could you each introduce yourselves and tell where you're from and what you do? Thank you.
So I'm Jameel Abdulrehman. I'm Thrombosis Toronto General Hospital, and we're here with a bunch of thrombosis experts talking about what we've been seeing at ISTH. So we'll start with Joseph Shaw. So why don't you tell us what you saw interesting today?
So I'm a thrombosis fellow from the Ottawa Hospital, so just to talk about two abstracts that I found were pretty interesting. One of them is looking at a new potential direct 10A inhibitor reversal agent. So it's actually similar to andexanet alpha in a way, but they tried to circumvent some of the limitations with andexanet alpha. So it's a factor 10 zymogen, but they delete the binding site for apixaban and rivaroxaban. So it actually just allows coagulation to happen without any effect from the anticoagulant that the patient is taking. And they looked at its effects by looking at thrombin generation, and it really seems to be promising. So there was complete reversal of all of the thrombin generation parameters without any overcorrection. So, and that's even with andexanet alpha. In some studies, you can see some overcorrection, and that feeds into that thrombotic risk that people are maybe afraid of with the TFPI interaction between andexanet alpha and TFPI. So it's very early days. It's currently in phase 1. They're still doing pharmacokinetic studies. This was an animal study, I should say, in rats and in monkeys. But from the data that they're presenting, it looks really promising. And also just wanted to highlight that there's also going to be a poster tomorrow night at 6:30 looking at more pharmacokinetic data on it. So.
And you mentioned that works with rivaroxaban and apixaban. Did they look at the other anti-10As like lomolecular heparin or fondaparinux?
No, and I should actually say their data was edoxaban and rivaroxaban. But I believe someone asked that question, and I don't think that they've looked at that either. Or I'm not sure if they really know whether it would work or not, just given that it was specifically the DOAC binding site. So
so now we're just on the phase 2 stuff.
They're still doing phase 1, so I think they need to. There were a lot of questions about immunogenicity, so people were worried about antibody production to factor 10, and could that lead to problems down the road? They didn't really have that data just yet, so I think that'll be one challenge that they'll have to, surmount before this moves forward. So
interesting, perfect, thank you.
Yeah,
and we have Dr. Marc Carrier as well.
Thank you for having me, Jameel. So yesterday I saw a presentation that really helped me to tailor anticoagulation in the setting of cancer-associated thrombosis. As you know, when we use the Thrombosis Canada algorithm, one of the important steps is to assess for drug-to-drug interactions. And when you look at narrative reviews, tamoxifen is an inhibitor of glycoprotein P and CYP3A4, and therefore can potentially increase the risk of bleeding by increasing plasma concentration. And a great review of the ISTH data from Ontario, including about 5,000 patients, or I should say 5,000 women receiving tamoxifen compared to other aromatase inhibitors that showed no difference in the risk of bleeding. So important, because when you have women on tamoxifen and they need to be on a directal anticoagulation for prophylaxis or treatment, the interaction is not clinically important, so I can scratch that off the list of things to worry about.
Yeah, and definitely an interesting study, because I know we have a lot of patients who have had clots on tamoxifen, and then they're on tamoxifen for long term.
Exactly.
And then it's nice if we can put them on a DOAC rather than lomolecular heparin or something else. So definitely very interesting study.
Absolutely.
Yeah, and so it was aromatase inhibitors. It looked, I think it was letrozole, and what was the other one?
Anastrozole.
Okay, great. And no difference in bleeding.
No difference. Actually, it was lower for the women that received tamoxifen. It's 2.5 versus 3.3 for those on aromatase inhibitors. So very practice changing. And published in JAMA Open.
Perfect. Thank you. And we have Dr. Tsu-Fei Wang.
Yeah, thank you, Jameel. So my name is Tsu-Fei Wang. I'm a adult hematologist at the Ottawa Hospital. So yesterday, also in the same section, I found this abstract pretty interesting from Dr. Sanfilippo in the U.S. that she was looking at trying to look at how to identify high-risk bleeding patient for a patient with cancer-associated thrombosis. Because as we all know, we have quite some risk assessment model for thrombosis. But we really don't have a risk assessment model for bleeding. And bleeding certainly, because cancer patient bleeds, and it certainly is on a lot of people's mind, and also kind of distort clinician from putting them on prophylaxis. So it turns out we really don't have a dedicated bleeding assessment tool in cancer patient yet. So what Dr. Sanfilippo did is she used the large VA databases, including probably more than or close to 8,000 patients, trying to evaluate how good the performance of the currently available bleeding assessment model that's not derived in cancer patient. Including the very well-known the HAS-BLED score, the hemorrhage score. And I think they also look at the most recent one, particularly developed in the cancer population, the CAT bleed score. There's a few more to really look at, looking at their statistics, which just help us to look at the performance. So a little disappointing in that is really all the available scores perform modestly. I think the best one is the hemorrhage score, but even still with see statistically of like about 0.6, which just to give people an idea, C statistical 1 is perfect and 0.5 is pretty much tossing a coin. So 0.6 is really modest. And so I think that just tells us that we definitely need to improve on that. Yeah. And hopefully, I know a lot of groups are working on, hopefully in the future, we can have a dedicated and performing better risk assessment model to help us really to identify patients with high risk of bleeding, and it really can help us tailor the anticoagulation strategies.
Yeah, it's interesting because a lot of the scores that you were mentioning, because they weren't developed in people with, cancer clots, like you're talking about HAS-BLED, which I think was AFib patients and like oral warfarin.
Yep.
Right,
exactly,
and hemorrhage
right.
is also AFib.
Yep.
So many of these studies, non-DOACs, non-BTE, so it's very challenging. So it's definitely a big research need to find a good score for these cancer patients and VT patients.
Yep, completely agree.
Okay,
yep.
Awesome. Okay, thanks so much. And we have Dr. Yan Zhu.
Hi, everyone. My name is Yan Chu, one of the Thrombosis Fellows at the University of Ottawa, and it's a pleasure to share one of the abstracts that I found was quite interesting. This was in the session that was today at around 11:15, titled Bleeding in Anticoagulated Patients, and it was presented by Dr. Catala and colleagues, looking specifically at risk factors for major GI bleeding or gastrointestinal bleeding among patients who are treated with anticoagulation for venous thromboembolism. So, in terms of background, GI bleeding is one of the most common sites of bleeding among anticoagulated patients. About 1 in 3 patients who do suffer a major bleed on anticoagulation do so within the gastrointestinal tract. And, we tend to typically think of gastrointestinal bleeding as something that comes and goes. You may get hospitalized, you may have to receive some transfusions, but in fact, they do have significant impact with respect to the risk of all-cause mortality following such an episode. So these investigators looked at registry-based data to try to come up with risk factors in whom major bleeding from the GI tract may be more common, and to identify groups of patients in whom primary prophylaxis may be a reasonable option. And so using over 87,000 patients from a registry, they identified several risk factors. So active malignancy, prior major bleeding in the GI tract, which are pretty intuitive, but also some things that are not incorporated currently into the models that Dr. Wang had just talked about, things like HAS-BLED or hemorrhage score, such as esophageal varices, abnormal prothrombin time, which may potentially, suggest some underlying liver disease potentially, or some sort of coagulopathy, renal dysfunction, and use of corticosteroids. And so could these be additional risk factors for gastrointestinal specific bleeding in whom, we need to be certainly more vigilant about risk of bleeding, and to tailor our therapy accordingly are areas of further investigation. So I thought it was quite an interesting and thought-provoking abstract.
Yeah, yeah. And did the study look at different types of anticoagulants causing as risk factors, like different DOAC types?
Yeah, that's an interesting question. And in fact, they included all patients who were treated with anticoagulation, but did not substratify within at least the presentation itself by types of anticoagulants. So I think certainly, for example, among patients with gastrointestinal primary unresected malignancy, one would expect that by choosing, certain modalities in terms of agents of anticoagulation may expose patients to higher risk of bleeding versus another. So I think there are certainly more work certainly to be done in this realm. But certainly, I think a great start and an interesting topic.
Yeah, perfect. Thanks so much. All right. Well, thank you everyone for being here with us, and we've enjoyed your thoughts.
Thanks, Jameel.
Yes, that was great. Thank you all for joining us today. And thank you, everybody, for listening. We appreciate your participation, and thank you for listening to Clot Conversations from Thrombosis Canada. We welcome your comments, questions, and suggestions on the podcast. And if you have any recommendations for future podcasts, please send them to us at info@thrombosiscanada.ca. Please subscribe so that you are notified about the release of new episodes. And don't forget to check out our website for educational programs, clinical tools, and guides. Also, please consider donating to Thrombosis Canada to support our ongoing efforts to reduce morbidity and mortality due to thrombosis. Have a good one. Take care.